And it's my great pleasure to be here to give the presentation. In the first few slides, okay, it's not moving. So in the first few slides, I'd like to give you some introduction about the institutes I'm currently working on. The National Taiwan University College of Public Health was established in 1993. But when we look back the history, the NTU Hospital and the medical school was established in 1899, very early, and the university was formed in 1928. And the Institute of Tropical Medicine was born in 1939, and this institute was renamed into Institute of Public Health. And in 1972, the undergraduate program was established. So here is the NTU Hospital. This is the university. This is the building we are located. And this is my colleagues and students. So my institute, there are in total 9 primary faculty members, including 6 professors, 2 associate professors, and 1 assistant professor. And we have a big group of jointly appointed faculty members and adjunct faculty members. So the institute is currently chaired by Professor Cheng. He is a specialist on quality management, patient safety, etc. And my colleagues are doing research on a variety of healthcare issues, including health economies and quality of care, etc. And I'm perhaps the only one who is doing occupational health policy in my institute. And because I am responsible for 2 required courses in my institute. One is called the Principle of Health Policy, another one is Public Health Administration. So in these 2 required courses, healthcare issues and national health insurance issues are often used as case for discussion. So I'm also familiar with healthcare problems. But in terms of my own research, my research interest has been focusing on job stress and occupational health policy. And currently, I'm working with the government to improve the worker compensation system, which is also a social insurance program. So in this talk, I'd like to present, first of all, the demographic and health transition of Taiwan. And secondly, I'd like to give an overview of the development of national health insurance and the reform. And lastly, I'd like to discuss some problems we are currently facing, and I'd like to talk about some issues the government are working on now. So for the first part, Taiwan has also experienced very similar problems encountered in other countries, including rapidly aging population, changing disease patterns, and also we have observed increasing social inequality in health. So this slide shows the population density of Taiwan. As you can see that the Taipei area is having the highest level of population density. And Taiwan is a small country with a population size of 23.4 million, and most of us were Han Chinese, but we have a small group of Aboriginal groups and foreign-born residents. This slide shows health transition of Taiwan. As you can see that the death rate has been decreased rapidly since 1920s. And the birth rate remained high up to year 1960s, and afterwards we have observed a dramatic drop in birth rate. And the fertility rate in Taiwan has been the top one, the lowest around the world. So it is a population crisis. And for life expectancy, for male, it has been 77 years old, and for female, close to 84 years. And Taiwan, we are facing the problem of aging population. So as you can see that the working population, the size of working population has been shrinking. And we have the increasing number of elderly population and decreasing children. The size of the people under 14 years old has been decreasing. And the speed of aging is considered very high in Taiwan as compared to other countries. So this line indicates the percentage of people aged older than 65 years old. So we expect to reach the super age population very soon, and the speed might be much greater as compared to the neighboring country like Japan and South Korea. And cancer has been the #1 cause of death in Taiwan since the 1980s. And currently, cancers account for more than 28% of total deaths, following by heart disease, cerebrovascular diseases, and pneumonia, diabetes, etc. The following 2 slides, I'd like to give you some examples of health inequality in Taiwan. This slide shows geographical inequality in all cancer mortality. You can see that this area, Yunlin area and the Taichung area are having the highest mortality rate for all-cause cancer. And these areas are the socioeconomic status were lower as compared to like Taipei area or other part of Taiwan. And if we look at cancer of respiratory system, we can see that the highest mortality rate is in Yunlin, where the major petrochemical industry is located. And when we look at heart disease and liver disease, which is a leading cause of death in Taiwan, we can see that the eastern coast region are having the high mortality, and that is where Aboriginal people are located. Okay, so the second part, I'd like to give you a quick overview of the development of national health insurance in Taiwan. So this slide, first of all, I'd like to point out the rapid growth in number of hospital beds in Taiwan, which indicate the growing healthcare need. And the red line here indicates the changes in the number of physicians per 100,000 population. So before year 1970, the size of a physician was very low, and that was because of very strict governmental control. So and also we can even see the decreasing trend of physician number, which was due to a brain drain problem. In other words, some well-trained physicians migrated to other higher income countries during this period of time. But after 1970, the government have to initiate several policy reforms in order to promote healthcare system in Taiwan. So the more and more medical schools were established. And since 1978, the government started some program to evaluate the quality of care, hospital cares. And in 1980s, many policy interventions were initiated, including the passage of Medical Care Act, which regulate the quality and the training and professionalization of healthcare institute. And also the medical resources was being controlled by the government by regionalization policy. And the National Health Insurance Act was introduced in 1994, and that was actually a political decision during that period of time, because we have the first presidential election, and the competing political parties campaign for universal health care. And over the past 15 years, we have seen rapidly increasing size of physician. So here you can see the majority of them were Western, for Western medicine, but we have a small group of people who are specializing on traditional or Chinese medicine, and there are some dentists. And the red line here indicates the change in GDP in Taiwan. And the red line here indicates the change in coverage rate, the social insurance for healthcare. Okay. So before the introduction of national health insurance in 1995, Taiwan have some social insurance already, including labor insurance and insurance for governmental employees and for farmers. And currently, the coverage rate for for healthcare is close to 99%. So NHI of Taiwan was established based on the two main ethical principles. One is social solidarity, another is social justice. So we believe that people should help each other, especially we should provide more health care to the poor, because they may face a greater health risk. Okay. And the principles include compulsory for all citizens and legal residents, and the contribution, the premium should be based on people's ability to pay instead of the health risk. And the service that they received at the hospital or the clinic should be the same. And the program tried to make the best use of the limited healthcare resources. There are some key features of Taiwan's NHI. We have just one insurer. This is a single payer system. So the bureau is called the National Health Insurance Administration. And the coverage is close to 99%. And the accessibility is considered quite good, easy to access, and we have the short waiting time. And the services provided by our providers are considered comprehensive and with high quality, which cover outpatient services, medication, rehabilitation, traditional Chinese medicine, inpatient care, etc. And the contribution is mainly based on payroll, the salary. For a regular employee, the premium is shared like this. Like the employer will have to pay the 20% of the premium, and the employer 70%, and the government 10%. But because there are some many people who have no employer, so the government will have to take care of them. Okay. And the co-payment is also considered law from the international comparison perspective. The co-payment for outpatient care is fixed, but if you are referred by your primary physician to hospital, you can lower down the co-pay. And we set a cap for inpatient care by year. And another feature of the Taiwan's NHI is that there is active participation of many interest parties, including the providers and professional groups. patient rights groups, labor groups, and many NGOs. So there are many groups who are very interested in NHI policies, and usually there are a lot of debates whenever the government passes new policies. And another feature is that the data management. The NHI provide a good source of data for research purposes. And the government have initiated many policies trying to reform the NHI, so I classified them into the 3 groups. The first type of policy reforms focus on the premium. The government have proposed, and the Congress has passed the policy to increase premium by having the supplementary premium based on incomes other than salary, which includes bonus, business bonus, part-time jobs, business execution, investment gain, etc. And the government have tried to reform the premium by replacing salary by household income, but this policy has been blocked. And additional income is from tax on tobacco products, which is since 2002. The second type of policy reforms focus on the payment. So how much the National Insurance Bureau should pay the providers, hospital and clinics. There are a lot of debates, and I will discuss that in the following slides. And the third type of policy reform focus on benefit. So the patients now are required to pay more co-payment, and starting from 2017, so very soon, the patients, when they go directly to hospitals, they will have to pay a higher copay. And also, we have problem of doctor shoppings, which means that some patients who are heavy users, they abuse the system by visiting too many times. Okay, so there are some policies trying to restrict the overuse problems. So in terms of the payment reform, there are 2 major types. One is macro-level payment reform. So we call it global budget system. This is negotiated every year between NHI and providers. So the providers will have to negotiate with NHI, and they decide the amount of payment for the coming year. And if the payment, if the services go beyond the negotiated volume, then the provider will not be able to get pay for that extra part. Okay, so the policy has been, several policy has been passed. And for the second type, micro-level payment reform, they are including the case payment system, which was established since 1995. So the providers were paid based on the procedure they performed. And since 2001, another scheme was proposed. It's called Pay for Performance. So the providers received a payment from the National Health Insurance Bureau based on their performance for each individual patient. And there are also some other programs being proposed, but like DRG was also blocked last year. Okay. So this table summarized some key health resources indicators of Taiwan with comparison of other countries. Taiwan spent a total, on average of 6.5% of GDP on health expenditure. And the hospital bed is considered much lower as compared to Japan, but if we compare to the average number of OECD, it's a bit higher. Okay. The physician, we seem to have the shortage of physician in Taiwan. when we compare to the more advanced countries. And we have the, I think, extreme shortage of nurses. Okay, so it's quite low. Okay. So the third part, I'd like to discuss some problems and challenges we are facing. And I summarize into 4 problems. The first is the rising healthcare expenditures. And the major causes are aging population, advance in medical technology, and the overuse problem because of we do not have the gatekeeper mechanism in Taiwan. So every patient is free to go to visit whoever physician he or she wish. And patients also can go directly to hospital, okay, to tertiary medical centers. And the problem of the providers also play an important role because the providers are dominant by private sectors. So they are free to compete with each other, and some pro-profit practice to some extent induced by inappropriate payment system of NHI are also considered the reason why we are having a rising healthcare expenditures. So whether or not and how to reform the payment to providers and how to regulate the patient-seeing behaviors, and also whether or not we should establish the referral system, these issues are being heavily discussed in Taiwan nowadays. And the second problem is that we have the overcrowdedness problem, especially in tertiary healthcare facility. So those causes include the easy access and preference of patients. They prefer to go to medical centers for their minor disease, and economic incentive of tertiary healthcare providers and insufficient manpower. As you can see that we have problem of nurses shortage. So again, policy issues are surrounding payment and benefit and the family physician system, referral system, and manpower issue. And we have also a lot of debates on whether or not to include a physician include a physician in the coverage of the Labor Standard Act. And the government now agree that the physician will have to also follow the working hour regulation. And there are a lot of debate and discussion about the nurse-to-patient ratio regulation. And the third problem is medical legal disputes and medical violence. This is a student in my group is currently doing research on this issue. The causes include increasing strain, physician-patient relation, heavy workload of healthcare workers, inappropriate expectation of patients, and pro-profit practice and promotion of client-oriented work culture by some providers. And we have problem of defensive medical practice. Some providers are afraid of being sued. Okay, and also medical violence seems to be a big problem, and the problem has been increasing. So there is some regulation trying to ask the employer to implement preventive measures to prevent medical violence. And there are a lot of discussion about compensation for medical, some damage caused by medical violence or medical dispute. But the last problem, I think this is the underlying problem of all the observed problem, that is the increasing privatization of healthcare providers, or the increasing commercialization of healthcare. So here I like to draw your attention to the public and private share of our providers. And I will skip this table, and I would like to draw your attention to this figure. So this slide shows the change in number of public hospitals versus non-public hospitals in Taiwan from 1989 to 2015. the total number of hospitals has been decreasing. That is because the hospitals are merging. So smaller hospitals are being merged into the super big hospitals. And you can see that the hospitals are dominated by private sectors. And if we look at the clinic, the primary healthcare providers, clinic, you can see that almost all providers were private. Okay. So the challenge is that we are facing increasing healthcare demands due to many causes like aging, etc. But at the same time, we are seeing the government, or the shrinking role of the government in the provision of healthcare, an increasing privatization and profit-oriented tendency of healthcare providers. So I think that to solve the problem, we cannot just rely on the reform of NHI, but we have to adopt some other policies to ensure social equity and economic efficiency in healthcare services. Thank you for your attention. I will skip.